heart appliance, but what we are expecting is to force forward the position of the condyles and to see this transform into growth. And this is a case, very, very old case, so I should renew this part, but I'm a lazy man. And now instead that this material that was the triad that is in a paste formula, I was using, now I use the dry gel, which is definitely more, that's definitely easier to use. But anyway, there is no essential difference. I'm preparing an introduce patient in a different position, more advanced. I'm helping myself also with an anterior jig, but I'm not using this anymore. And I let the teeth on one side to erupt into a cheap class 1. This is the case at the end of treatment, but this is just a functional treatment that you can do in many other ways. We are starting a research of the use of dry gel in advancement in mandible in young children. This will be probably mostly the work of Paola Merlo because she has a lot of young patients in treatment. I mostly treat adult patients. And anyway, we have the impression that this is a very, very good way to treat class 2 cases. But of course, nothing strange in this. The question now that we are facing is whether this can be possible in adult patients. And so here we have a very big discussion. Because in the orthodontic world, among opinion leaders, there are opinions are not the same, but I would say that the majority of the experts on TMJ are supporting the idea that the condyle should be right in the middle of the fossa, leaving enough space for the disc to stay on top of it, and with maximum number of occlusal contact. And this is supported by Dawson, supported by Okazon, and many other. If you think, I know here in Chile, Roth and the Face School is very popular. So all this group of orthodontists, of implantologists are insisting that the condyle should be there. Shouldn't be more back, shouldn't be more forward. So they leave a very little possibility of variation of the position of the condyle. I know that when you work following the Face group, they tell you, first of all, you have to take away the occlusion you have and see whether the mandible is more forward, more distal, and then you, once you have aligned the teeth, then you do surgery. In my opinion, this is a little bit too radical, but of course, if you have a condyle which is a little bit different from this opinion, and you are 100% convinced that it has to be there, that's the only way. I'm not really convinced that this, it's the only position where you can stay. But try to understand me. I'm not saying that the condyle there is bad. I'm just saying that the condyle can be a little bit more forward than that, not very much more distal than that, but anyway, can be in a different position than that, and the patient can stay well, no pain, good function, and life goes on. So if I'm okay and have no pain and I have a stable occlusion, personally, but this is an opinion, it's not mathematics, it's not biomechanics, but personally I would leave this occlusion, leave this position of the condyle. are discussing about the condyle, we should also consider other position. This diagram is what Åkesson described for vertical forces, and it says that the temporalis and the masseter are guiding naturally the condyle in that position. He does not consider occlusion. And I think this is a quite questionable point, because those arrows really represent the direction of traction of these two muscles, and that's correct. But did you remember what we saw yesterday about inclined planes? The inclined planes transform these forces with no extra muscle work. So you don't need another work from other muscles to have a mesial or distal force. Are just the inclined planes that are transforming this force. And so I believe that these assumptions that the muscle give always this vertical direction that leads the condyle right there in this position might not be correct. Anyway, we have another possibility from centric position to have a condyle which is displaced towards the posterior surface of the fossa, and this is a position to which the prosthodontist in maybe 30 years ago were on purpose pushing the mandible to register the bite. They were calling it centric relation. And nowadays there is an even more general consensus in the idea that this is a rather dangerous position. It's a rather dangerous position because when we push back the condyle in that position, we reduce the space for the disc. We tend to elongate the temporomandibular ligament that is represented there, and we reduce the space for the soft tissues posterior to the condyle, and in that area there are a lot of pain sensor fibers, nervous fibers. So pushing the condyle to the posterior teeth can be dangerous. Is it always like that? Not at all. We will see, and I've seen in the last 10 years probably the CBCT of 300 patients. And I've seen a lot of patients without a symptom, with the condyle that was pushed back. On the other hand, I've seen a lot of patients that had pain, and many of these had a condyle that was back. So I think that this is a risk factor for having problem, but it doesn't mean that you have a condyle back and this, oh, you're gone. You have pain, you have click, you have all problems. There are patients that have a condyle in that position and they are perfectly fine. Anyway, I wouldn't recommend to put the condyle on purpose like that. In the 90s, there were two brothers. They were dentists and they were working especially with sportsmen, trying to make those splints that were trying to increase the performance of athletes. And they had the conviction that if you were bringing the condyle forward with their splints, they were getting better sport results. This has never been demonstrated and probably it's not true. But as a matter of fact, they were doing this for many years, and I can't imagine that they were making this advancement of the condyle and they were provoking damages because they were trying to improve the performances of these sport people. And here we have a big discussion and a big problem. So is this position that from now on I will call Gelbe position, which is in the middle of the eminentia with the condyle brought forward, compatible with the good function and no symptom? The problem with this position, as we read from the great book from Professor Åkesson, is that this position, according to him, can be maintained only by a hyperactivity of the lateral pterygoid, the upper lateral pterygoid. And so it says, well, this position can only be stabilized if the lateral pterygoid muscles gives to us an extra work. And according to Åkesson, this extra contraction of the lateral pterygoid can be a problem. And a lot of orthodontists, a lot of neonatologists are convinced that many of the TMD and many of the muscular problems that we have in TMD patients are related to the hyperactivity of the lateral pterygoid. So we have this problem that, according to some authors, we might have this hyperactivity of the lateral pterygoid and this leading to pain and instability.